Thank you. Thank you. I haven't done anything yet. You guys don't need to clap for it. Let me start, right? That's a good one. Good evening. Thank you. I know it's hard to come on a Thursday to listen to somebody speak about technology an hour and a half. I'll try to make it as interesting as possible. I've done this a few times before. So the idea is to talk about two specific things. One is strictly digital workflow from start to finish, whether it's a single unit, whether it's a full arch. And the second is to talk about how all these different digital workflows kind of fit into it. Because the harder part is not buying the technology, the harder part is making it work, right? Uh, and and believe it or not, when I say this, that I have bought the technology in my office and I learned everything how to use it, but then I'm not the one using it. In other words, my staff uses it. So I haven't taken an intraoral scan in a patient for about 5 years. Do I know how to take it? Of course. It'll take me 5 minutes to do it, but if I give it to Debbie, it'll take about 10 seconds. So the idea is one of the biggest pillars of benefit of technology is that you are able to delegate a lot of your work to your staff. So I'm going to talk about that part as well. I'm going to try to cover little business side of it, little workflow side of it. I'm not going to bore you with a bunch of studies. I'm going to show you how clinical attachment got better with this study and that study. I'm going to try to keep it as practical as I can make it, right? So the first question we have to ask is why? So all of you are here. The topic is to talk about digital workflow, especially with XGuide, navigation. Why navigation? Just by show of hands, how many of you place implants? So he needs coffee. Okay. Uh, so obviously there is something that is missing that you want to change because otherwise, like, right? Do you know 75% of the implants that are being placed on a day-to-day basis are being placed freehand? So 75% of implants that are placed freehand. Less than 20% of implants are being placed with a surgical guide. Less than 5% of implants are being placed with navigation or robotic arms. So we're talking about 5% here, right? So one is why. I inherited this case. It was done in the Bay Area, not to say because I'm in Bay Area, but the patient moved to Sacramento. And this was done about 15 years ago. It's a straightforward 8 implant case. You can see probably a bar in it. The implants look pretty nice, healthy, in bone. The patient comes in, he sits in the chair. This is his smile. And I'm like, okay, can you give me a bigger smile? That's a bigger smile. So what's wrong? It's not peri-implantitis. Say it again. No bone reduction. So what does that mean? If there's no bone reduction, why is there no bone reduction? This was done, to add insult to injury, this was done by an oral surgeon and a prosthodontist. They didn't talk to each other. One placed the implants, the other restored it, but nobody talked. So the idea is, I can show, so the other topic I lecture except digital is implant complications. I have thousands of slides of implants gone wrong because that is one of the best things to show people. You scare them and they're like, oh, I don't want to do implants, right? So I can show you hundreds, if not thousands of cases, something like that. 21-year-old girl had number 8 and 9 done. 8 fell out, 9 looks like this. Now, shift the focus. You are the patient. Don't think of a patient, think you are the patient. You went to a periodontist or an old surgeon or a general dentist, whoever, and this is what was done for you. Now what do you think about it? Or this. Can anybody guess why this patient was referred to perio? He was referred to perio, but why was this patient referred to perio? Take a guess. I mean, there's no. I'll buy you dinner. How's that? Huh? No. No keratized. Anything else? Say again? Too deep. Think of it. There has to be something which is kind of out of the ordinary for me to ask you this question. Why would this patient be referred to me? Who said that? So somebody asked me, can you please put a connective tissue graft on number 10? It will never work because it is a ceramic restoration. You cannot grow soft tissue here. The only thing I can do is I can take the implant out. So my response to the doctor was, I'm sorry, thank you for the referral. The patient doesn't need CT graft. The patient needs an implant removal. By the way, there's decay on number 9 distal. Right? So that was my letter to them. How's this? Same. Can you do a CT graft on number 8? They all have one thing in common. All the cases I'm showing you. This is between 6 and 7. Right? Or this one, straightforward. This is easy. I mean, anybody can do it. Right? Or my favorite. I can go on and on and on. But think of it. What is one thing that is common in everything I'm showing you? And that is, this is a 8mm implant placed in the palatal root of number 3. So the implant is 8, the restoration is 24. 3 times bigger. They all have one thing in common. They were all done freehand and there is no planning done whatsoever. None. We all have bad days. So if I do 100 implants without planning and freehand, I'm sure 85 are going to be fine. But I'm not going to remember the 85. I'm going to remember the 15. And they're the ones who are going to come back to me. Right? How's this? This is a true story. I hired a periodontist to come and work for me, right, in Sacramento. The first day he converted a case and he said, you're missing 3 areas, I'm going to put an implant. Okay. He placed 3 implants, fully flapless, or whatever minimal flap he opened, completely without a guide. All the implants are going through the buccal plate, through the lingual plate. So this is how the patient went home. I lecture for implant complications and for X-Guide. How long do you think that guy lasted with me? 1 day. Because after I saw this, I said, it's never going to work between us. Because my referrals do not expect me to send this. Now, how many of you are general dentists here? All of you? If I send this case to you to restore, how angled my abutment has to be to restore it? And then, would you send the case back to me again? You will say, let me find out, periodontist in whatever zip code this is, and you'll find another one. You expect me as a periodontist to do better work than, right? This is a simple fix. A guide should have been made, or X-Guide should have been used, planning should have been done, implant should have been placed. Now, this is done. You know, the worst part about poorly placed implants, they always integrate. The best ones fail, but the worst ones are like, I'm there, buddy, I'm not coming out, right? So these will integrate. So the patient came back after a week. So I'm going to step back. How the alarm bells were ringing is because my assistants are used to me. They saw this. So I have different offices. So I was working in a different office. My assistant called me. She's like, you will not know what we did today. I was like, what happened? This is what happened. The implants were not looking good. I think he should have not done it the way he did it, whatever it is. I called the patient. I said, I need to see the patient for follow-up. It's my practice. It says Arora Periodontics. It's my name. So I had the patient come back. The patient came back. We removed all 3, reverse torqued it, made a guide, and put the guides again. Luckily, the way he had done it, the bone was still pretty intact because they were all going through and through. They were not vertical, right? So then comes the mantra. The mantra is disappointment is equal to expectation divided by reality. So how big is this? What is the patient's expectation? What is the patient's reality? What is it that most of us can assume that how bad or good something is going to look? Most of us, right? So we don't have to predict a whole lot. If I do my things right, I can keep the expectations in control, and I can, reality speaking, I can tell them how it's going to look, and they can be agreeable to it or non-agreeable to it. So my idea today is just to go over that part with you. So the question was why? If I have to plan everything, then I have to use a guide to place an implant. If I'm going to use a guide to place an implant, I have two options. I can either physically use a guide, which is made of with a plastic material, or I can use an X-guide machine. X-guide is only telling me where everything is. So why is it called navigation? In navigation, what is happening? Your car is moving and you know where your house is. So there are two things talking to each other through satellite, right? Your car knows where the house is. Satellite is telling you where the car should go to get to the house. That's what navigation is. In an implant surgery, there are two things that move: my hand and my patient's head. So if I track my hand and if I track my patient's head, and the cameras on top tell me where my hand is and where my head is, my patient's head is, I know exactly where my implant is going to go. And if I can get it under half a micron or under a micron, that is even better. If it tells me at any given point that where is my handpiece, my handpiece has a QR code kind of a thing which is talking to the camera on the top, and my patient is wearing a tracker which communicates. So my hand tracker communicates, tells me where exactly I am. So I'm going to show you all these cases today. So this is just a surgery. This is a nerve, obviously, and then this is real-time drilling. Where I am in contention with the nerve. I'm putting an implant next to the sinus, right? Where am I in connection to the sinus? The funny thing is, let's ask a question. When you do a freehand surgery of the ones who place implants, you're placing a number 19 implant. How off do you think you are from where you should be? So you took a CBCT, you looked at the scan, you're like, you know what, I'm going to put an implant right in the middle. How off do you think you are when you're placing an implant? And I'm talking about somebody who's an experienced surgeon. How many degrees would it be? 2 degrees, 15 degrees, 90 degrees? How much do you think your variation is going to be by freehand? There's a study on it. We don't know. They did a study. They took 20 oral surgeons and periodontists who, on average, do about 500 implants a year. And they let them do single unit implants. And the answer was 10 degrees. So experienced surgeons are off by 10 degrees. Now, here's another question. Practical. You send me a case for number 19, and my implant is 10 degrees off. You would not care. You send me number 9, I'm 10 degrees off. I lost you as a referral. And now you have to make an excuse for a patient. Well, there's an angle department, we can do it. We can do a bigger thing. You call the lab. It's always the lab's fault, you know. So it could have been avoided. That's what I'm trying to say. Right? So let's talk about why navigation. So when they did papers, they talked about, okay, how accurate are we? So they did statistic numbers to give you an idea as to why a guide is important. Now, you don't have to use it, but I have to make a case for why is a guide important. The accuracy of every time we place an implant is off by 10 degrees if we do freehand by an experienced surgeon. And I'm not talking experienced surgeons here. I'm talking about somebody who doesn't do a whole lot of implants. An average dentist does about 5 to 30 implants a year, right? General dentist. An average specialist does about 100 to 150. I do about 600 to 800. So if I'm doing that many implants, do you really think I'm that good that I'll not have a bad day? And if I get 10 bad cases in 600, that is 60 bad cases. That's a lot of bad cases, right? What about attorney fees? Right. So the idea was that, okay, when they did studies in vivo, in vitro, they kind of figured this out that, you know what, for it to be accurate, we have to use a guide or a static guide. Then they compared a static guide, which is a plastic guide, to a navigation guide. So it's very simple. When you're putting an implant with an X guide, this is what you see. This is the blue dot is the tip of your burr or your drill. And this is telling you how deep are you going. So now let's say I'm doing an all on 6. I have 6 implants. I'm planning 6 implants with 6 different depths. When I tell the machine I'm putting number 3, it knows I'm putting a 10. When I go to number 5, I'm doing a 15. If I'm going to number 8, I'm putting a 13. So it automatically knows what size. So this 9 o'clock position changes accordingly. Okay. When I'm drilling, this is usually yellow, yellow, yellow. When I get close to it, it becomes green, green, green. I've hit my mark. If I go beyond, it becomes red. Now, when I do a statistical analysis of it, it says that if I'm doing freehand, I'm off by 10 degrees. If I'm doing an X guide, I'm under a degree if I'm experienced with it. Right? If I'm using a physical guide, I'm off by a degree to 2, which is still not that bad. But when I look at a 2D lateral position, I can control my implant to under half a millimeter. And if I'm putting it freehand, I'm about off by 1.5 to 2 millimeters off. Now, these numbers seem very small, but we deal with everything very small, right? Now, when I compare that, okay, let's look at what's the benefit. Is it singles, units, or double? I started using X-Guide for single units. And it was a lot of fun, single units here and there. But now, if I do a full arch case, I don't want to use a regular guide. I want to use an X-Guide. So if I have planned my case and I'm using an X-Guide, it is relatively super straightforward and easy for me to do it. Now, every time you use an X-Guide, you will use this build plate. And you put your handpiece either with an implant or with a drill. And what it does is, can I see that? The plate? You have it?
Which plate are you looking for?
Yeah, there you go. So if I put my implant on this, the camera reads this and the camera reads my handpiece, which is stuck on it, and it tells how deep my drill is. So it is measured to the T. It is not just something you're trying to do a whole lot of it, right? So this is a case we planned. We're going to do 6 and 8. This is planning and this is delivery. No physical guide, just placement based on what we're planning. When I started using X-Guide, I used to do all my planning myself. Now I have delegated it to a third-party lab, a remote lab, who gets into my system, plans all the cases for a week, and I go click, 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 I'm good with it, and then we do the surgery. Because the planning was taking forever too. So whether it's a single unit, placement of an implant, whatever. The idea is to just follow it to the T. So this is flap, this is placement of the implant, followed by bone profiling. We use a burr called on1, followed by thing. There's another case using an X-Guide, placing 18 and 19. My pictures have to be flipped, sorry. 18 and 19, implants placed. No physical guide used, X-Guide, 18, 19 done. We place a base or a one-time use abutment on it, and they put a healing cap. The patient comes back. After 3 months, we scan it, and then we deliver the crowns based on that. The benefit of putting that base on the same day is because you're taking everything supra crestal out of it. So you're increasing the height. So you're not touching the implant connection ever again after the day of surgery.
That graft material.
This one?
Yeah.
So we extracted 17, and I think it was Puros, or it was, I don't remember now. So this is how an event looked like. This is a 6 implant case. It is planned, okay, we're going to put a 5.5 by 10. We're going to put, so all these. Then the patient wears a clip, and I go and drop my implants based on that. So that becomes easy, right? But why? Why is it? So this is a case planned. This is a case planned in the software. We're going to do 18, 19, and 20. This is the planning part of it. And this is the execution of the same thing. Now, we can do this freehand. But how cumbersome is it to figure out exactly at what point 18, 19 emergence profile is going to look good and 20 is going to work? You have to do a lot of planning and this and that. So the idea is, see, if you do a lot of surgery, you worry about post-ops. What's going to limit your amount of post-ops? How quick you do a surgery. And I'm not saying quick by just doing it for the heck of quickly, but if you're planning it, your treatment time reduces. I want to share something with you. And I'm not saying it because of any other reason, I got up my surgery started at 6:30 in the morning today. I did 2 full arches. Then I went and came here after that. So if I had to do those 2 arches freehand, I don't think I would be done by 4 o'clock, 5 o'clock. Because everything is planned, I literally have to get into my driver's seat and go. Placement is easy because I know exactly where my placement is. The placement gets done because everything is planned to the T, the temporary is planned ahead of time. I'll show you all those cases. It becomes easy in that regard. So the whole idea is not to be fast. That's not the goal. The goal is to be more predictable and just have a workflow which makes you fast, so to speak. So this is another case. So the patient is going to wear a clip which is attached to the patient. That is what is telling the camera where the patient is. My handpiece is attached to another clip, and that is where it's telling me where my handpiece is. As I'm drilling it, I'm in yellow. The moment I get to 10, that means that's the size of the implant I'm going to place. I'm going to hit 10. If I go past 10, so -1 is 11, -2 is 12. The other part is, it's a little hard to see here, is that at every given time, it is telling me the depth, and it is telling me how off am I. So if my implant was planned here, and I'm using my drill to place here, if I'm off by 0.01 degrees, it is telling me you're off by 0.01 degrees. So if you play video games, this is a piece of cake for you. I don't play video games. This was a hard learning curve for me. Because your hands work a little different when you play video games, I think. So if you're placing an implant and you can get it between 0 and 1 degree of your plan, that is ideal. Right? So this is how it started. You remember these? When I was in residency back in 2006, we didn't even have a CBCT that time. We used to plan our cases like this. This is useful, but completely useless. And what I mean by that is, you are basing the placement of an implant on a stone model. You have no idea where the bone is. You have no idea where everything is going to fit, but you know, oh, I'm going to put an implant in these 3 places. I want to be in the center. So kind of a useful tool, but not really, not accurate at all. That led to this, surgical guides. Because we place so many implants off, we're like, well, we need to start putting it a little bit more planned. So we start using surgical guides. Single arches, double arches, everything like that. If I know where my implant is going to go, then I can also plan for a temporary. How many of you temporize your immediate implants and anteriors? Let's say number 8, right? You get a case for number 8. You're going to extract, place an implant, and then temporize it. How long is your appointment? An hour. When you're temporizing it, what are you using to temporize? You're going to use a shell or something like that? No. Okay. Uh-huh. Mm-hmm. So then you're picking up the scan at the time of surgery and then, okay. So the idea is, that's exactly what I was going to say. The idea is that if I know where my implant is going to go, so this is fracture number 8, then I know where my temporary can go to. Now, if I know the exact position of my implant prior to placing it, I can kind of design my temporary prior to placing it too. So all I have to do is, once my placement is done, I scan exactly where my implant is, make some modifications, my temporary is ready, load up the file, and 3D print it. So walk with me for a second here. If I look at a case like this, 18 years old, missing laterals, 7 and 10, comes to us, I can very well do 2 implants and send him back to his dentist and say, you can wear an Essex for 3 months. Or I can say, well, why don't I make you a temporary at the same time, which is going to give me better profile. So when the patient goes back for his finals, I've got the scalloping done. Right? Now,
Those are immediately loaded, though, aren't
the implant placements are immediately loaded with temporaries, but they're out of occlusion, of course.
they? They're loaded on the insides of it.
Say it one more time. I didn't follow what you
They're
said.
loaded on the insides of it, but not on the same.
Yes.
The person goes in a protrusive.
Right. So let's talk about temporization for a second. There are 2 ways to make a temporary. Temporary can either be removable or it can be fixed. Right? When we think of a patient we think of, well, we can give him an Essex or we can give him a stay plate. But when you think of yourself, you don't want an Essex for yourself. If you're a patient whose number 9 has to be replaced, you would find a dentist or a pedontist or an oral surgeon who's willing to give you a fixed temporary in that case, because you know how uncomfortable you're going to be and what's the possibility of your papilla. So let's talk about removal. Two ways to do it: tissue supported, which is a stay plate, or it can be tooth supported, which is an Essex. The other is you can do it fixed. One is if you place an implant, you can temporize it using a temporary abutment. The other way is you can use a 3D printed temp that is bonded to two teeth if you don't get the stability you want at the time of placement. As a first rule of comfort, the patient is always going to choose something which is fixed. No patient is going to say, well, I really miss my staples. Can you give me one of those? Right? If you look at the shear match, so this patient came in, number 10, extraction, used an X guide, placed an implant. After the implant is placed, this is about 10 years old. So I'm going to show you the new way to do it. This is the old way you used to do it. Right? A temporary shell, a temporary abutment is placed that snaps into it. Once it snaps into it, you have a 3D printed temporary, you put some composite in it and pick it up. Now this is blocking the screw access hole. So then there's an end, there's a burr that comes in that goes right through it and makes this into a screw retained temporary. And then you place that. So this is how she left home. This is 3 months follow up with the final. Now, if I do the same thing, this patient came in, number 7, extraction, placement of the implant, putting the temporary snap abutment, cutting it to the desired height, taking composite, picking it up, attaching it to the analog, taking a drill that goes straight through it, making it into a screw access hole on that end, and tightening the screw, and we're done. This was easy, but this was cumbersome. It still took some time, right? It's about an hour after your surgery or 40 minutes after your surgery. So how many of you refer to peri or oral surgery for implants? Do you expect them to do your temporaries or no? Is there pedontist here? I think it's expected now, right? So in Sacramento, there are 14 of us. Nobody else except me wants to do it. I'm very happy about it. Please don't do it. I'll do it. So my selling point to every referral of mine is, I will do it, she won't. So when I go, it doesn't matter what implants I place, right? My selling point or my thing is I go to every GP and say, if you send the case to me, I'm going to temporize every crown that I can. If you send the case to her, don't take it lightly. If I send the case to her, then it's not going to be restored. So you're going to have to do that part for you. So this was good. I did a lot of these cases, but this was very cumbersome. It took forever to do it. I did it because I was trying to grow my practice, not because I really enjoyed doing it, right? I can show you case after case. This is another one. We placed number 7 for her, didn't get any stability, added the bone, added the graft, the membrane. We printed a temporary shell, and it had a vertical on number 6 and number 8, attached it, cut the wings, did some bonding composite, and that's how the patient went home. She comes after 3 months, and this is her final that was delivered. This is before, this is after the final restoration. Then comes the fact of angulated screw channel. If I can plan it, I know how much angulation I can correct. Angulated screw channels can correct 25 degrees. If I don't do freehand, if I plan my case, I know how much angulation correction I can do, how every time I'm going to place an implant, it is going to come out through the cingulum or through the palatal aspect of it, because I've planned it beforehand, right? Now, this is number 6. The patient had 6 and C. Number 6, extraction implant. This is 3 months final. So it kind of became different. This is another patient, number 9. He had a resorption, extracted number 9, atraumatic extraction, placement, did the drill through the palatal aspect, had the temporary done before, placed the temporary at the time of placement. So every case I got for front, if it satisfied the parameters, I wanted to place a temporary going forward. 8 and 9, young female, decently high smile line, extracted, X-guide placement, place the implants. Both implants are spinning. They are not, there's very little stability whatsoever. Put bone, let them heal, have her come back in 4 months, exposed it, used custom healing abutments, and then delivered her final crowns by her GP. So the reason I'm showing these cases is, these are old cases. The reason I'm showing these cases is because everything went through some kind of a planning. And at that point of time, the problem was that every digital tool that we have was not talking to each other. The scanners would not talk to the printers, and the printers would not talk to the X-guide machine. So that was the hard part. But now it has changed. Now it's not the case. So why do we use technology in the first place? 75% of us place implants without any surgical guides, which to me is a very high number, right? Do you see increase in implant complications in your practice, and that is what you're treating more of now, or no? Specifically for you, you're periodontist, right? No, also. So do you see a lot of implant complications being referred to you now than before, or no? Hmm. Hmm. So my practice is about 40% just implant complications, right? And I see more of it because a lot of my competitors don't want to do it. So I'm like, sure, send me a case, I'll take care of it. Not the fun ones to do, but it is what it is, right? So if I see that many, my goal is to see at what level can I avoid these complications. At what was done. Now, implants are going to fail. That's kind of expected. But how many failures were avoidable? How many failures happened because of poor placement, right? So we look at a CBCT and intraoral scan. That's kind of match made in heaven. You need these two tools to plan any case. You need to start with where the bone is. You need to start where the soft tissue is. You take these two files and you merge them together. That gives you some data that you can then use to do your case planning. Now, why is intraoral scan so efficient? It gives you two parameters. One is trueness and one is precision. Trueness means if I take an intraoral scan and scan her mouth, where the cusp tip of canine on number 6 is to her scan and in her mouth, how close is that value to each other? That is how true my scan is. Precision is 5 of you guys do the same scan on her, and all these 5 different scans, what is the closeness of all these cusp tips on all the scans? So this is the theoretical part of it. Now, what's the practical part of it? I have 5 assistants. They take 5 different scans on her. What's the possibility that we all take PVS and get the same level of accuracy? And what is the possibility we use our trios and get the same level of accuracy? I can train anybody to do an intraoral scan on a patient. Whether it's an assistant after a month of experience or 10 years of experience, they'll have the same level of intraoral scanning capability after a few tries. So that eliminates the human factor. So that is why technology helps you in that regard, because your trueness and precision just got better. I'm going to talk about numbers for a second, right? Why should you invest in technology? It's all about money, right? At some point of time. Okay. You'll ask him a question. Okay, how much does an X-guide cost? He'll say, well, it costs you 30 or 40, whatever the cost is. Then you have to think in your head, well, does this 40,000 make sense to me in my practice? The first response is, no, it doesn't. Right? Why should I invest 40,000? It's working fine. I'm still doing all the implants I want to do. Let me make a case for it. 2016, I was able to buy my first CBCT. I was sending at $300 a piece a scan to a lab to take my CBCT scan. With that being said, I was sending 10 scans a month. So they were generating a revenue of $3,000 a month from me, which is about $36,000 a year from me. I used to get a gift basket at Christmas time. Thank you for all the referrals. It's a nice gift. Okay? So I said, why don't I buy my CBCT? Like I've kind of paid my dental chairs and I've bought some things and I can buy a CBCT. So I did the math. I said, if I buy a scan machine, even if I pay half of it in installments, I'm still taking home $18,000 a year. That's my revenue, which is my ROI. I'm making money out of it. We take an average of about 60 to 70 scans a month in my practice. So if I buy a scan machine today, I can pay the thing off in 3 months. Once you have technology, you use technology. When we didn't have it, we would not go more than 5 to 10 scans a month. Now, business grows because you're able to see more, you're doing more scans. I think you should take a picture of this. This is a very important slide that I want to go over in detail with you, right? This is finances. So you're going to get technology, finances all in the same time. We all run our practice. Most of us don't know what our overhead per hour is. Some of us do, most of us don't. What does that mean? We take all our overhead costs, which is our rent or mortgage or whatever, you add all that payroll, or you take all that and divide by the number of hours you work in a month. That is your overhead per hour. So if you work 20 hours a month, that's 20. If you work 70 hours a month, that's 70. Whatever number of hours you work, you divide that number of hours, and that is what is going to give you the thing. Now you take your procedure. So let's say I'm placing an implant. I'm going to take the cost of my overhead, add the cost of an implant, or add the cost of a guide. That's my cost to do the procedure. So when somebody says, well, the implant is only $400, why are you charging me $2,000? Well, because my overhead is there, right? Whatever the patient paid me on top of it is my profit, right? So with that being said, I calculated my overhead, and I'm in Sacramento, so I'm cheap, minus $700. I'm sure yours in thousands, if not a bajillion, I don't know. You guys live in Bay Area. So minus $700 an hour. So the way I look at this is that if I'm working 8 hours, our production has to be about $5,600 a day for the ship to run, right? If I take an intraoral scan for a single unit impression for number 19, and I use a PVS impression, I have to spend a full hour doing that. But if I take an intraoral scan, I get done in 20 minutes. I don't have to package anything. I don't have to ship anything. I don't have to take a bite. I don't have to use Alginate or PVS, nothing. I scan, put the scan body, scan it, and I send the patient home. 20 minutes, I'm done. And on top of it, I don't do it. Debbie does it. I'm doing something else. I'm on Instagram, Facebook, whatever you care, but I'm doing something else, right? I'm not doing this part. Yes, I'm in the building, I'm checking it, I'm making sure my things are fine, but I'm not the one scanning it. But if I'm taking PVS, I'm the one doing the whole work. So with that being said, I'm spending about $450 extra per patient per impression. Now add that, if you do 1,000 crowns a year, 1,000 times 450. So what's the cost of a scanner? 20,000. You'll pay it off in 2 months or 3 months. So you have to visualize, what does technology do? The most expensive thing in your practice is,
A dull bird.
That's a good one. I don't use that. The most expensive thing in your practice is your time, not a CBCT, right? So when I look at, so the reason I'm telling you all this, there's a case I'm trying to make. Why do we go to X-Guide, for example? I used to spend about $50,000 plus in surgical guides a year, which is a lot of money, right? I was like, if I go to X-Guide, it costs me $100 a case. That went from 50,000 to 10,000, and I get the same level of accuracy. So why would I not jump on it? So I jumped on it. There's no impression, scan, plan, and we're done. So let's look at this case, number 8 and 9. She fell, both 8 and 9 are loose. So let's have a discussion. What options do we have? One option is we extract it, 8 and 9. Okay, let me go back. So if you're looking at 8 and 9, you can see two things: loose teeth, soft tissue deficient, and because I'm going to take teeth out, bone deficiency to place implants. So I have to grow soft tissue, I have to grow bone, and I have to place my implants. One option is I extract 8 and 9, do a bone graft, do a soft tissue graft, and give patient an Essex or a stay plate. Option 2, I do an immediate implant if I can, do a bone graft, do a soft tissue, and give the patient Essex or a stay plate. Option 3, I extract, I place bone graft, soft tissue, and I do temporization with fixed crowns at the same time. what would you prefer? As a patient, not as a physician, as a doctor, as a patient. If you're the patient whose 8 and 9 has to come out, what would you like to be done from A, B, and C? If all parameters are checked. C, right? So she comes in, we extract 8 and 9, we place the implants 8 and 9, we scan it at the same time, 3D print her restorations. When the restorations are getting 3D printed, at that time, I've made a small incision on the 8 and 9 vertical, and I've done a soft tissue graft, and then I've sent the patient home like this. Now, if I do this freehand, yes, sir.
Those two incisions you made, what's the rationale for that?
So I basically made an incision here, an incision there. I took a soft tissue piece of skin from the palate, and I put it in like a tunnel. Say again? Just tunneling. Yeah. Just to augment the buccal tissue, right? Now, what is technology I'm using? I'm using a CBCT and intraoral scan to scan the case. I'm using an X-guide to place the case. I'm using my 3D printer to do the temporization. If I told you this is about an hour surgery, I think that's pretty decent. But if I didn't have any of these tools, this would take me a lot longer, right? So this patient comes back in 2 weeks, and we take her sutures out. The incision is there's actually no incision. The only incision we had was more on the palatal than on the buccal. Then she comes back after 8 weeks or 10 weeks. This is how it's healed. These are temporaries. We take the temporaries out. They're both palatally, I mean the screw axis hole are palatal. We take the temporaries out. This is our soft tissue. We take this, we scan it, we send it to the GP, and I'm like, okay, can you please go ahead and place the finals? He does the finals. I don't like it. I think they don't do justice to what has gone in this case. So this is impressions. This is the lab's side of it, followed by placement, and these are the two templates that were placed, finals that were placed.
You did those on your own?
I don't do final restorations. I send them back. But I don't like the final restorations. I think my templates look better. Huh? Because I was trying to do it more narrow. They made this botch thing. The funny thing is that I saw it and you could see my reaction. The patient's like, I love this. I'm like, oh, great. If you like it, who am I to say anything? But I don't like it personally. I genuinely think these templates looked a lot better than those finals did. And that's just 3D printed. It's not like there's not much thought that has gone into it. So the case I'm trying to make is it's not me. It's a lot has to do with just using the technology in the right space, right? So this gets more fun when you do full arch cases. I'm going to show you a full arch surgery using it. So full arch concept was simple. Dr. Malo invented it in 1990s and said, you take 4 implants and you place them, and the patient should not be wearing a denture because it's a disability. If he wears a fixed prosthesis, it's better. Oh, we have a nerve, we have sinuses. He said, angle the implants. If you can angle the implants and put a 30-degree multi-unit on it, it should work fine. This is how it started. Right? The problem, what happened was that in the last 30 odd years, surgically, there's only 2 changes that have happened. One, we do zygomatic implants. And second is we use guides because we have placed so many implants so poorly, they were like, well, somebody used to tell them how to place implants. So now a guide helps us. But restoratively, everything has changed. We used to do denture teeth. Now we do full zirconia proceras, right? We used to do metal bars. Now the metal bars are less. It's more about direct zirconia on multi-units with no metal interaction whatsoever. So why digital workflow? Why do we need for a full arch digital workflow? Now, you work for Clear Choice, right? Clear Choice has, I mean, till about 3 years back, they had no digital thing. It was all set, let's do it, kind of a thing. Now you're in private practice? So my assumption is now you're not doing a whole lot of, like you're doing planning and placement and all that. Right? So I start this case with this. Oh, by the way, I have a whole white paper written on what scans you need to take when. So if somebody needs to do it, just text me or send me a message. I'll send it to you. It's when you're doing a full arches, there are about 11 scans you take. Facial scans, white cap scans, all those scans. So when to take which scan, I'll just send it to you as a thing so you can review it, and it's a white paper basically. Now, the idea was simple. This is a case, comes in, this is how he goes home in temporaries, and this is his Nobel Procera final. So we plan first, we place, then we print our temporaries, and then we do Procera as finals. The idea is that yes, anybody can show a beautiful case. It's not about the destination, it's about the journey. How hard was the case? If you plan it, getting from A to Z is relatively easier. If you go commando on it, and I'm going to do this part, the tricky part becomes in the middle. You place your implants, now the lab has to figure out, your GPs have to figure out how to restore this case. So we talked about 10 issues when it comes to a full arch case, or why digital is the answer. Number one is records. If she's a general dentist who sends me a case, I scan and place, I can transfer records to her, and both of us can transfer records to a lab. You don't have to take 3 different records for the same thing. That's one. Second is because everything is digital, it's easy to plan. I can be on my laptop anywhere and I can plan the case based on that. Third is my conversion is easy. Has anybody been in conversions when you're doing a full arch case that you go to somebody's office and help them change from implants to a hybrid? You know what I'm talking about? Conversions? No. Conversion is a full arch case is being done. The surgeon does the case, for example, and now you have to restore the case with a fixed hybrid. So either a lab or the general dentist or the prosthodontist will go to their office and help them convert it. That's called conversion. When you're doing 3D printing, you don't need an extra set of hands. You can do everything in your office. You don't need one extra hand. Even as a surgical specialist, you can do it. Last comes, because your temporaries are better quality, they don't break as much. So let's say you're doing a full arch case and your temporary broke. I can print another one. It takes me 30 minutes to print it. I don't have to call my lab to get a new temporary, a new denture made. Because it is one piece, they don't break as much. When I'm putting cylinders, there are weakened spots at every cylinder. They break more. So let's talk about a full arch case. Now, some of you who are older than me or are my age would know what I'm going to talk about. Some of you who are younger than me will have no idea what I just going to show, right?
Am I younger than you?
You look like it. So this is a 2006-2007 case, right? The patient has a full upper lower that has to be designed. So our plan was, for now, we're going to give her an upper denture, and for the bottom, we're going to extract these teeth and give her 5 implants for an all-on 5. So she comes in. This is, by the way, before CBCTs were there, right? This is my first all-on 4 case I ever did. At that time, CBCTs were not even out. 2006 is when I did, I think. They came out in 7 when I had access to it at least. This is my surgical guide. My goal is my implants should be between that hole, and I'm good, right? So I extract the teeth, I level the bone, I put gutta percha on this point and have the patient bite and send the patient to take a pano. That gives me some idea where my bone is, right? Now, after I level the bone, I put 5 implants, put my multi-use, put my cylinders on it. And then I take the most interesting tool in our office, a dental floss, and I wrap it around every cylinder. Then I take Durolay and attach it to every floss. Then I section the Durolay and then I reattach it. You have no idea what I'm talking about, right? I knew it. That's why I said people younger than me would not know. The reason is Durolay is going to shrink. So when you section it, now you can reattach it, the shrinkage is gone. Anyhow, but that's good. You don't need to know this. Like why? People rode horses before us. We don't need to know how to ride horses. So you cut the Durolay, you reattach it. Then you take a denture with the same hole and you put it in the patient's mouth. You take a bunch of composite in a syringe, in a monojet, and shove it in the patient's mouth and have the patient bite in centric. The reason you have a rubber dam is because it's hot. Now the patient bites this for 5 minutes. 5 minutes he bites it, you wait, you unscrew it, take it to the lab, spend it polishing, You would start this case at 8:30 and you'd be lucky getting out by 4 o'clock. You could not pay me enough to do this again. This was so darn painful to do, but we did hundreds of cases like that because there was no other way to do it, right? Now this patient comes back after 3 months. I'm like, oh, here you go. Everything is healed. Now the patient is yours. Start the patient. So now you're going to start with primary impression, secondary impression. Sorry, did I go fast too fast? Sorry. Oh, I went through all that. Sorry. Did I miss a slide? No, I didn't. I'm sorry, I missed a slide. I'm sorry. So when this patient went back, you send the patient back to GP. Now the GP is going to take primary relations, secondary relations, jaw relations, trines, male patient, 2 trines, female patient, 10 trines. By the time you're done, it's like an 8-month, 10-month ordeal. So when you did a full arch case, you hated it and your patients hated it. Here's another way to look at it. Do you think all of a sudden all these super centers came from nowhere? Why all of a sudden our teeth are so bad? Why all of a sudden everybody's getting an all-on-4? Did something change in 20 years that we stopped brushing our teeth in 20 years? No. Why? There's so many full arch centers now that they weren't there 20 years ago. One word: technology. It is so easy to do it now, which was not there. So nobody wanted to do it 20 years ago. People like him were doing it because that was. But that's what I'm saying. I mean, it's like it was you and a prosthodontist, clear choice doing it, but nobody else wanted to touch it. But now everybody's doing it. So I practice in Roseville. Between my office and the mall, it's about 3 miles. There are 6 super centers. Super centers. They only do full arch cases. So how all of a sudden they opened up? That's the other part of it, yes. But then the other side of it is their cost is less than half of what my cost is. So then how do I be relevant, so to speak, right? I'll discuss that later. But then somebody said, well, we have a CBCT and Arora scan. We kind of went better with time. So we were like, oh, we can plan the case better. We have the 2 basic tools. It tells us where to place the implant. We can do it. So we can plan the case much better. We're going to figure out where our incisor ledges is. We work backwards, how much bone to reduce, place the implants. And all I have to do is, once I plan the case, my recipe is to just follow it blindly and get it done. The problem with this was that because I'm using a surgical guide and because my whole thing is planned to the T, I don't have a way to move it. It's like my Tesla is stuck and it can only take me from Sacramento to the airport. I cannot take a Starbucks break. I cannot move. I have to stick to the plan because everything is sticking to the plan. Their temporary is designed on these 5 implants. It's only going to fit in this 5 places. So when the cases went, you place the implant. It was the same thing again. One second. I think I went back, sorry. So when the cases were done, everything went well, everything went fine. There was no problem. But to anybody who does surgery would know that cases don't go as per plan. But if you have everything designed to the T, you have to stick to it. So in this case, for example, I'm placing 2 implants in 19 and 30. My trabeculae is so big, both my implants literally fell into the mandibular bone. So I have a 4 millimeter hole with the implant inside the bone at an angle. So when the cases went well, you had guides, different guides which will tell you where to place it, how to place it. Your temporary is designed to fit on all the same 5 spots. You had the patient bite, in-centric, worked great. Till it didn't for certain cases. So the issue was we're trying to retrofit what we have previously made. So whether we have a denture we're going to convert or we have a prefabricated temp we're trying to convert, we're trying to retrofit our implants. We have no luxury of movement. Now, that made it a little tricky because all these before and after cases look great, but the journey became a problem. That how do you, if something changes in your surgery, all of a sudden a 2-hour surgery became a 4-hour surgery. Your temporaries are changing, your placement has changed, you moved an implant from 19 to 20, it's not the same. Now you take this, you call it a pain point. Pain point means it didn't go as per plan, so I need to do something which I need to change. So you need flexibility in your surgery, and that is what you get if you use a next guide. Then comes handoff. At what point as a surgeon do I send the case to you and say, can you go over and finish the rest of the work? So I'm going to show you a few things. This is what I use in my practice. CBCTs, X-Guide, ICAMs, sprint trays, printing, the whole 9 yards. So this is a very complicated slide, but it's very simple. I'll explain to you. Please take a picture of this. This will give you an idea as to how full arches work. It just looks scary. It is not, I promise.
You need to revise that slide.
No, this is
It's
amazing.
so scary.
Wow. Thank you. So everything in blue is data collection. Everything in whatever color you want to call it, purple or violet, whatever, is fabrication, whether it's temporary, whether it's a final. Green is planning, and salmon is the actual surgery. So what I mean by that is, what is the first thing you need to do for a full arch case? You need to take the patient's scans. How many scans do you need to take? You need to take the patient's intraoral scans, top, bottom, bite. You need to take the patient's CBCT. You need to take a bunch of photographs, occlusal sides, occlusal views, buccal views, smile line. You need to take a patient's facial scanner. So this is how you start. You take the patient's CBCT, intraoral scan, pictures, facial scans. Anybody has ray scan in their office to take facial scans? You know what ray scans are? Right. Ray scans are about $17,000 to $20,000. Then last year this app came out, which does the same thing for about $200 a year. Killed the market, right? So I can show you this app. You take this app, you stand in front of the patient, scan the patient's face. It gives you a 3D image of the patient's, a complete 4D image of the patient's face. And it's a file, an STL or OBJ file that can easily be texted to your lab. It's that simple, right? So you take these and you put it together. And you digitize the case. So before I'm doing anything, I'm showing the patient how I'm going to do his full arch. I've taken his measurements. I've removed his teeth virtually. I've placed my implants. I'm going to place 6 of them. I'm going to do an FP1. This is how you're going to look like. Are you happy with this? Yes, let's do it.
You play that music. Show the patient.
That is just to wake you up. That's all. Now you take the software and you plan the case. You have 3 different ways to plan it. DTX is one of them, which is owned by Nobel. We use DTX a lot. It makes it easy because I can communicate with all my partners with this. X-Guide is the software we use. So this is just an idea. This is the planning phase of the X-Guide. This is the execution of the X-Guide, of placing the implants. And most labs would like to use ExoCAD. What time is it? 8? Good. So I can do freehand. I don't like to do freehand, but this is like one of the few cases I've done freehand. Because the moment I place the implants, then it's somebody else's problem. I don't have to worry about it. But then that person's not happy with me. Your implant is too buccal, your implant is too palatal, I mean, all that. Other option is I use a guide. They work well. It's expensive. Every case adds another few $1,000s worth of just guide placements. So an average case with with a regular guide is 1,500 to 2,000 at least plus. Right? The other part, I have to stick to the plan. I don't have the luxury of moving things around. So then I like to use X-Guide. Why? So this is my patient. I extracted her teeth and I put my marker on patient's number 9. I drilled 2 holes and put screws into it. And now she has a marker on her head. Right? I just have to put my 4, 6 implants depending on where I want to place them. Pterygoids, number 3s, number 6s, whatever I want to do, right? Once my patient is clipped in, we call it, once the patient is clipped in, every time the patient moves, my camera tells me where the patient's head is. Here's another fun fact. When I'm doing this surgery, I'm not looking at the patient, by the way. I'm looking at my TV. So my hands are here, but I'm not looking at the patient. The hardest thing is to get past that. Because we're so used to looking at the patient, it's very hard to look up. You're like, what if I hit the nerve? You won't, because you know where the nerve is and you can see it on the screen, right? So now my implants are placed. The next thing I want to do is, I want to do a temporary. So I need two things for my temporary. I need a soft tissue scan to tell me where the soft tissue of the patient is after I suture. So I'm going to go back to my slide. I did the planning, I did the surgery, now I'm here. I'm taking records again. I need two records. I need one to know where my soft tissue is when I suture it. I need the other one to know where my implants are, which I've placed. So I'm going to start with my intraoral scan to scan and get me soft tissue. And I'm going to use photogrammetry to figure out where my implant positioning is. How many of you use photogrammetry in your office? What do you use? But do you know what tool he uses? Which photogrammetry? I can? Okay. Mhm. So this is a soft tissue. I'm trying to figure out where the soft tissue is. I put my implants, I put my white caps. We're just scanning it so we know when we design his temporary, we can figure this out, right? So I've done my soft tissue. This is a soft tissue scan with the trios. Once this scan is done, my lab only needs to know the precise location of my implants. So we use photogrammetry. There are 4 different ways to do it. The concept is every machine is going to use the XYZ axis of the implant positioning of the multi-unit, right? Once they take all this data, they overlap it and make it into a file which tells the lab where exactly the positioning of the implant is. Now, somebody might say, why don't you take an intraoral scan using a trios? The reason for that is because trios and photogrammetry, or intraoral scanning and photogrammetry, work completely different. When you use a trios or when you use an intraoral scanner, it starts with number 3. The further it goes from 3, the more discrepancy it gets. So your best scan is number 3. I go to 5, that's my second best scan. I go to number 10, I'm off. By the time I hit 14, I'm really off. Because I'm trying to start with 1 and go there. So my best picture is him. And as I get to Junie, I'm off completely, right? Or off by a significant amount. Photogrammetry is, I'm looking at 4 or 6 or 8 implants at the same time individually. My eyes can't do it, but picture my eyes are able to see 8 people at the same time. The easy way to understand this is, you'll never forget, is the example of wine. If I give him a bottle of wine and say, can you please put some in your glass, and from your glass add to her glass, from her glass add to the 4th person, 3rd person, can he predict how much wine he needs to give it to everybody? There's no way. Because everything is dependent, a variable is dependent. So there is no way he can predict how much wine we need to give everything equally. He's going to drink the wine too. But now I get 5 people to serve 5 people wine and say, please only fill half of it. 5 different bottles of wine. They all get individual wines. The possibility of all being equal is very high. That is photogrammetry. That means I'm measuring 5 people completely independent of each other. Once I measure all of them, then I make a file out of it. So that is what photogrammetry does. And that is what makes it so accurate. So when it measures these with ICAM, it measures these 4 implants. It is not looking at, it's looking at individual implants, putting it together and then giving you a file. So the accuracy of this is almost the same as accuracy of this. It's not going in a sequence. It's going individually. And that's a huge difference. Huge difference.
You have that stack?
Yeah. We'll talk about that.
Oh, okay.
We'll talk about that. That's what I'm here for. Thank you. So now, one might say, well, how about we figure out a way that he passes on the wine to her a little bit easier. So you have different ways to do it when you can overlap your impressions. You can put these scan bodies like lightning and 3D shining, polos. There are different ways to do it, but they're still not as perfectly accurate as just independent photogrammetry is. Now, these are 4 options we have, but I want to show you the benefit of this. Now, we all have heard the word passive fit. What does passive fit mean? That means if I put my prosthesis in a patient's jaw, I want to be able to engage all 4 to 6 screws, and it should not lift. I go to Journal of Prosthodontics. If my passive fit is under 100 microns, it's a good passive fit. If it's under 150 microns, it's acceptable. Do you know how to measure 150 microns? Anybody knows how to measure 150 microns? Nobody does. No dentist can measure 100 microns. So how do I know it's going to fit? We just touch and feel. When we put the prosthesis, if it screws in, I think we're okay. So somebody will say, well, I take a pano. The most inaccurate tool in our office is a pano. It only tells you wisdom teeth for old surgeons. It doesn't do anything else. You're better off taking a bite wing to confirm the seat. You'll see a pano, you'll always see a black circle around every implant that you've put a final on. It's not that it's just not that accurate, right? So here's a, if it's under 100 microns, it's good. Human hair is 50 microns. That means 2 human hair is 100 micron. You have to get that level of accuracy. You cannot even see under 40 microns. So then how are we measuring this micron inefficiency, right? So we do what's called the song and dance of tightening a tire. Anybody change the tire? How do you do it? This, and you go here, you go here. You're going in a sequence because you know you can't go in a sequence. You have to go in a random fashion. It's the same thing with all on fours. When you tighten them, you can't start with 3 and torque it and go to number 5 and torque it. 14 is never fitting. So the idea is you engage all of them little by little and then you tighten them. Hence the word tolerance stacking. What does that mean? Somebody explained to me and I was like, okay, this makes sense now. If I had perfect fit, indulge me for a second, if I had perfect fit, I should be able to put in my screw on number 3, torque it, and nothing should happen on 14 because my fit is perfect. But we are not there yet. And we'll probably never get there yet for a simple reason. It's called tolerance stacking. That means if I take an open tray, if I take a closed tray impression of number 19 of Nobel implant and open a brand new package of a Nobel impression coping and I put that to take an impression, that impression coping is off by 5 microns. For Nobel, made by Nobel, you cannot get machined surfaces that perfect. There is always going to be discrepancy. In a full arch case, it just magnifies. So now what happens if you're tightening it and you're really pushing on it hard? We all have done it, right? Sometimes screws are not engaging. You're like, let me make sure that sucker fits. And you're going hard at it. You're putting stress and strain on an implant because your fit is not accurate. What's going to happen to that stress and strain implant on number 14? Bone loss. So the best goal is, and we obviously can't measure it, the best thing to do is to get as close to measuring as possible. So going back to the same thing I was talking about before of doing accuracy of precision and trueness, when I take my iCam, which you don't have, if I take my iCam or my X-Guide and I'm measuring these implants, I want it to be accurate like a bullseye every time. I want high trueness and high precision. That is what is going to tell me where my implant positioning is. So I want it repeatable. So that means all 5 of you do the same patient, it should be repeatable. And second is, it should be the same as an anatomical value which was measured before. That is where it gets interesting. Now, papers, studies after studies have showed you take PVS, intraoral scan, photogrammetry. There is no comparison. Photogrammetry is way far superior and accurate when it comes to this. 4 years back, I started lecturing for Nobel on photogrammetry. I would ask the question, have you heard of photogrammetry? And maybe one person would say, yes, I have. 1%. Now when I ask, 50 to 80% of people have heard it because it is that easy to do and that fast to do it for a full arch case. So let's talk about X-Guide now. Where does X-Guide fit into place? This is a physical guide. This is a virtual guide. Same picture, right? This is X-Guide. It is presenting to you a virtual picture of how your implant should go. Let's look at his case. Has he been what? Interesting story. Somebody broke into my office at night and broke 2 windows. Right? I got a call from the police department at 2 in the morning. It was winter also. Like, please come in. Somebody broke your windows. 2 in the morning. I was fine. I go there. There are a couple of cop cars. They get this guy. He hammers the nails and blocks my office. Right. Next morning, I call this guy. He's a local window repairman, handyman, whatever you call it. So we have if you don't have it between you and me, this is one of the best things you do. In your office, in your front, waiting room, don't play news and sports and all that. That doesn't do anything for you. Have testimonials of your patients have videos of yourself talking about cases, nice, happy smiles, kissing some babies, and it has to look good. It will attract more patients than anything else you can do. You can put all the edgy TV and don't put news these days, by the way, but it can put edgy TV and sports and all that. Nobody cares. This guy was walking out of my consultation room and he said, "Doc, I have a question. Can you do something like this for me? I don't have good teeth." And he's a local handyman, and I did his case. We didn't even talk to him. He's not even my patient at that point of time, right? So I'm like, "Sure, sit in the chair." So once he sits, sorry, too loud. So once he comes in, we take his same thing, intraoral scans, CBCTs, facial scans, photographs, put all this together, digitize the patient. Now we're going to do his surgery. The surgery is we'll do a traditional all on X case, or I think we did 4 implants for him. We're going to use X-Guide to do his case, and we're going to use photogrammetry with X-Guide, which is called fast mapping. So he comes in, we plan the case, we're going to put 4 13-millimeter implants. First thing I'm going to do is I'm going to get him numb, elevate the flap, and clip him. I need to know where his head is at any given time. So we put 2 screws in his upper jaw, and then we attach a bar to it. He looks like this, a human with a QR code in his head, right? Once that happens, I extract my teeth, I level the bone. It's all measured how much I'm going to level it. I level the bone, extract the bone, extract the teeth, and then I'm going to go ahead and place my implants. I put my 4 implants. Once I place my implants, I do some bone profiling. I put my multi-units, and I need to do photogrammetry. My patient's already in the chair. He's already clipped. I already know where his head is at any given time. All I have to do is attach these scan bodies and take this camera. So the patient's lying down, put the patient up 45 degrees, take this camera, shove it in his head, in his face, and it reads all these scan bodies within 10 seconds to maybe 2 minutes. And then I use it and make it temporary. Let me ask you something. You're all general dentistry, right? If you had to take an open tray impression on a full arch case, how long is the appointment? How long will your receptionist say you need it for? Anybody? Geez, you're fast. For a full arch? No, come on.
Full arch?
Yeah.
What medium? What medium?
You're going to take a tray, make some holes in it, put some 15 minutes. Wow, that is amazing. 45. Maybe an hour for me.
Yeah, it's like a photogrammetry scan.
Yes? I'm not there yet. I'm going to talk about that also. No, it's fine. But let's say an average appointment is about an hour, right? I don't think you can do less than an hour. I mean, you take the temporary off, you put the multi-units, you put the scan, whatever you want. I mean, make the holes in the tray, whatever, right? I want to show you surgery, right? The same case I just showed you. So our start is at 8:30 in the morning. Between 8:30 and 10 o'clock, and by the way, this is not a speed contest. I'm not trying to show how fast I can do it. I'm trying to show how technology makes it easy for me, right? 8:30 he comes in. We get the patient numb. So everything which is in pink is what I'm doing. Everything which is in green, my assistants are doing. So I want to show delegation of that. Patient's numb, local for him, local anesthesia, elevate the flap. The machine has to be calibrated. That means the machine has to know that the software scan that has been loaded in this computer is the same patient who's in the chair. I can load her scan and sit in the chair myself, right? I mean, how does the machine know? I have to calibrate it. I put my implant. My implants are done. I do some bone profiling. My bone profiling is done. I put my multi-units. And the first thing I'm going to do is take those scan bodies, look like Michelin men. I put them on. Oh, perfect. You can pass these on. You know this. Why do you need to see it? Put them on, and it reads it. Right? The moment it's read exactly what positioning it is, this is fast mapping. It tells you you're good, you got the scan. I will send it to my lab. My lab is in Phoenix. I live in Sacramento. I live practice in Sacramento. So I'll call Jeremy and say, Jeremy, I sent the scan. He's like, yes, Dr. All looks good. I'll take this scan bodies out, put my white caps, finish my suturing, and then Debbie's going to scan this. Once Debbie scans this, we send the soft tissue scan. All he's doing at that point of time is, because we have planned the case before we did it, he already has a temporary that is made. He just has to put holes in the temporary where my implants are. That is it. We're not inventing the car on the day of surgery. So I have a full arch case tomorrow morning. He already has the whole plan done. I have to put my implants and send him a scan, and he'll adjust the temporary and put the holes where it's supposed to go. Give me 1 second. I'm going to finish this and then start. So the temporary is already made. He's going to put exactly the spacing at which I need the holes. Then the other part is that 20 different screws you can use. So you should know what kind of screw I'm going to use. He's going to ask me, I'll say Nobel screw or desk screw or whatever, right? Once that part is done, he remotes into my printer and starts my print. Now, printing can be done in different ways. You have an older printer, it'll take 45 minutes to print an arch. You have a newer Pro 2, it'll print in 30 minutes. You have a smaller build plate, 22 minutes. You go on a plaid mode, 16 minutes. So why is that important? You're trying to deliver the same day. So if I can reduce the printing time, I can finish the surgery. So for me to start my surgery today at 6:30 and by 11:30 deliver 2 separate patients, 2 separate arches, it will not happen if my printer is taking an hour and a half to print. So I'm not converting, right? I'm printing at that point of time. Once that happens, the printing is loaded. So we'll pick the small build plate, put it on that, print it. Once it's printed, cleaned, take part of that. One of your assistants would know how to paint it. Some are more artistic than the others. So use the one which is more artistic. And she does it. Once it's printed, deliver it in the patient's mouth, tighten the screws, have him look in the mirror, give him a bagel, have him eat. No. That is so stupid when people do that. I just laugh at it. Like, why are you making him eat a bagel? The guy is numb. You're like, oh, eat the bagel. You just did double arch for him. That used to be a thing for Instagram. And then he's done. So this is how the screen looks like when you're planning the case. In this screen, it tells me how much bone I have to reduce. This is where my nerve is. So all I have to do is it's measured, by the way. I'm going to put a hole here, hole here, hole here, 5 holes, like a postage stamp, and then connect the holes. My alveoplasty is done. So I'm not randomly making bone removal. Here's another side to it. The more I do implants, the less I remove bone now. So I'm doing more FP1s now because I don't want to remove more bone. So I did a case for somebody. The girl is 27 years old. She's 5 feet tall. She went to Clear Choice. Sorry, don't take it the wrong way. They said, we'll remove the bone, put some implants, this, that. She goes to another friend of mine who's a GP. He said, go to him. He'll do something different for you. We did 6 implants for her. FP1, little to no bone removal for her. So it is going to look like bridges, more like one piece with no pink of any kind, right? So this tells me how much bone to remove. So now I printed it. Now the patient comes back after 3 months. Now we take another photogrammetry scan because soft tissue is going to shrink. So I need soft tissue scan again. It's going to shrink. It's going to. Do you have Nuvia here in town? Have you heard of Nuvia?
3 months closest one.
Because they're doing 24 hours final, which to me is completely. I don't want to say wrong, but I don't know what. It doesn't make any sense to me. You're always going to have shrinkage. Surgery doesn't look good the first day. You're always going to have shrinkage. You're always going to have remodeling of bone. So when you deliver it the next day, what happens when you have spaces? So I don't know how this business model works. I'm clueless about that part. So once that is done, now the patient comes after 3 months, right? Still in my office. I will scan the patient again, take the temporaries off. So this is the patient's temporaries. Sorry, I went to a different case. We did denture for the top and hybrid for the bottom. Now he comes in, he's fully dentureless. I'll put my 5 implants on a dentureless case. I just need a tracker to know where my implants are. And then I place it, scan it, almost flapless. So healing is going to be easy because there's not a huge flap opened. And we do the temporary. So we take photogrammetry, design the temp, doing his fast mapping, and we have him all these 5 scanners. This says 44 seconds or something. So you just have the patient move and you get the scan done. The camera is reading the scan based on the tracker. Now this patient comes after 3 months. Okay, this I can go over there. So this is the temporaries. Now he comes after 3 months. I take his temporaries out, but I need to check photogrammetry again. What if his implants had some micro movement? What if his multi-unit was loose? So I'll retorque it, recheck it. I'll take another photogrammetry scan. Now he's not wearing a tracker. So do I put a tracker again? No, because the system already has him in the file. We can use it as a regular photogrammetry scan. And then you send the same file, design a new temp, have the patient be happy with the final temp, even if it takes 2 temps. Printing a full arch in your office is about $30. So whether I have to make 6 different temporaries, I have no problem. I just don't want to touch the patient's final. I want to have him happy with this temporary. So when he says, I got this, I love it, you go to a final. So that's easy. You take all the records, you tell the Procera guys that, okay, patient's happy with it. Can we now deliver? They just have to take this and transfer into a zirconia Procera. So you're not touching your finals. You're not doing adjustments to it. So this is his final photogrammetry, final scan, and then we deliver his final, top and bottom. So this is Joe's before, this is his temporaries, and this is his final zirconia. They all want white teeth as temporaries, and then they figure out we don't want white teeth. It's, you know, oh, it looks fake. I'm like, I told you before, you didn't listen to me, but fine. And this is his final. So I do the same thing in my office in 2 days. Like I'll go through 2 to 3 arches with you, start to finish, how we do it, right? From placement to planning to delivery to finalization, the whole 9 yards. And that's, I think, the flyer that you guys have. You can take a picture of this, send me any information you want. I'm more than happy to answer it for you. I've tried to take this topic and condense it in 1.5 hours. I don't know how much made sense, but I tried my best. So, thank you.